Hello, everyone. My name is Man. I'm a pharmacy resident. For my nephrology final presentation, I'm going to do a journal club about SGLT2 inhibitor benefit in chronic kidney disease by going through trial the AMPA kidney and DAPA CKD. For my objective of this journal club, at the end of this presentation, the audience will be able to identify the benefit of SGLT2 inhibitor therapy for chronic kidney disease, understand the practical consideration before initiating SGLT2 inhibitor for chronic kidney disease patients. In the background, chronic kidney disease increase the risk for kidney failure cardiovascular disease event. Sodium glucose transporter SGLT2 inhibitor have a kidney target mechanism of action and have been shown to have nephroprotective effect, especially in albuminuria patients. Chronic kidney disease. All patients with kidney disease, whether acute or chronic, should undergo an assessment of kidney function by estimating the glomerular filtration from the serum creatinine. Further evaluation will assess the quantification of protein urea, hematuria, cellular cas, kidney ultrasound, kidney biopsy, and elevate albumin to creatinine ratio. More than if it's more than 300 milligram per gram. Due to high blood sugar and high level of sugar, the nephron is able to keep the protein inside. For high blood sugar, for high blood pressure, the blood hit the nephron wall membrane and damage the glomeruli of the remaining nephron. For diabetes, the cell nephron become weak and the sugar will be excreted out uh, of the body. The high workload of the sugar and blood pressure will damage the kidney to progress kidney failure. Uh, Proteinuria is a sign to indicate the development of kidney failure. Treatment guidelines and recommended an angiotensin converting enzyme or ACE inhibitor or R, an SGLT2 inhibitor to slow progressive disease and even preserve kidney function. So for the indication of SGLT2 inhibitor, is reduce the risk of cardiovascular death and hospitalization for heart failure in adult with heart failure. Reduce the risk of sustained decline of EGFR, end-stage kidney disease, cardiovascular death, and hospitalization in adult with chronic kidney disease at risk of progression. Reduce the risk of cardiovascular death in adult with type 2 diabetes, and establish the cardiovascular disease as an adjunct to diet, exercise to improve glycemic control in adult and pediatric patients with age more than 10 years old for type 2 diabetes. So, for the mechanism of action, SGLT2 receptors are responsible for reabsorption of glucose from glomerular filtrate back into the circulation. SGLT2 inhibitor reduce the renal absorption of filtered glucose and lower the renal threshold for glucose and thereby increase urinary glucose excretion. Because of SGLT2 inhibitor reduce sodium resorption and increase the delivery of sodium to the distal tubuli. This may influence several physiology functions, including but not restricted to increasing tubular glomerular feedback and reduce intraglomerular pressure, lowering both pre and afterload of the heart, and downregulating sympathetic activity. For the summary, um, the population here for clinical trial that patients have chronic kidney disease with an estimate glomerular filtration of 20 to 45 and 45 to 90 and with the UACR at least 200. Patient in this population whether have not have like mixed between diabetes and non-diabetes. So they have 6,609 patients underwent randomization. Mean age is 63.8 years old. Gender 33.2% with male, and 54% not have diabetes. So for the gender, with 33.2% women, with 54% not have diabetes. So we can see the mix in between diabetes and not diabetes. Therapeutic regimen. Patient receive 15 weeks supply once daily placebo. After 6 weeks running, the patient blood and urine sample get collected. They were randomized to either receive placebo or empagliflozin. Patient will provide kidney status at each floor from 2 to 6 months per protocol. And the duration of this study is from February 2019 through April 2021. Finding that for the primary outcome, the composite progression of kidney disease show empagliflozin is 13.1% and the placebo 16.9% with the hazard ratio is 0.72 and it was statistical significant. The power of study was 90% with the p-value is 0.05 and the number needed to treat is 27. The secondary outcome of the hazard ratio for the comparison of empagliflozin with placebo show three separate hazard ratio. For kidney disease, progression is 0.71, death from cardiovascular causes 0.84, and then end state kidney disease for or death from cardiovascular causes 0.73. In here, we can see on the chart the progression of kidney disease when comparing when the patient is on empagliflozin, Jardiance, or placebo. So you can see that there's two different of the long-term use between empagliflozin and placebo here, and over time, more than like a year and a half, we can see the two different in the long-term use. There's a two separate between placebo and then empagliflozin. Another thing is that we can see the change in baseline with the GFR for kidney function. Uh, that in the long-term use, we can see in the beginning we see a big drop of the renal function to after 2 months, but over time you can see that the renal functions fall into a certain baseline, the range of the baseline, by using empagliflozin. But for the placebo, it keep worsen and worsen. And we can see that the difference here is that for total use it was 0.75 different between empagliflozin and placebo, but for long term the difference is 1.37 with 95% confident interval. So for the safety outcome for using Jardiance, ketoacidosis occur in 6 patients in empagliflozin group versus 1 patient in placebo group. The lower limb amputation occur in 28 patients in empagliflozin group and 19 in the placebo group. The incidence of serious urinary tract infection, hyperkalemia, acute kidney injury, serious or symptomatic dehydration, liver injury, and bone fracture were broadly similar to each other. There was no apparent evidence that empagliflozin increased the incidence of serious adverse effect. Let's look into the DAPA CKD trial. So patients also have the chronic kidney disease with the estimate glomerular from 25 to 75 with the UACR 200 to 5,000. Uh, Population side, we can see that 4,304 patients underwent randomization. The mean age is 61.8 years old. Gender is 33.1% with female, with 54% not have diabetes. This is another mix between diabetes and non-diabetes. So patient would require to receive a stable dose of ACE or R for 4 weeks before screening. dapagliflozin and placebo was randomization one daily, and trial visit will begin at 2 weeks, and then 2, 4, 8 months, and then it's a 4 weeks interval. So from February, the duration of this study from February to 2017 through April 2020. The primary outcome for composite progression of kidney disease, a decline, we can see that the dapagliflozin is 9.2% and the placebo was 14.5% with the hazard ratio is 0.61, statistical significant. The number needed to treat was 19, and power of the study was at 90% with the p-value is 0.05. A secondary outcome that is not separate like the EMPA kidney, it showed a composite of the secondary outcome for hazard ratio with 0.56 and it was statistical significant. And same like for Jardian, for Siga here showed the different in the long-term use for primary outcome after more than uh, a year and a half. We can see the separate, and it showed a 0.61 in here. And same thing for the GFR for dapagliflozin. We see the big drop in the beginning of the estimate GFR, and then over long-term use, we see that the GFR will maintain a certain baselines of the range, and then the placebo will keep worsening and worsening for GFR. For a safety outcome, diabetic ketoacidosis was not reported in any participant who received dapagliflozin, in two participants who received placebo. Neither diabetic ketoacidosis or severe hypoglycemia was observed in patients without type 2 diabetes. Clinical implication: SGLT2 inhibitors show kidney protection, especially for patients with chronic kidney disease (CKD) with or without diabetes. Two trial SGLT2 inhibitor, DAPA-CKD and AMPA-KIDNEY, determine the clinical factor for initiating this therapy in patients with CKD. They focus on CKD with urinary albumin creatinine ratio more than 200 milligram per gram, regardless of their diabetes status. So we can see that patients with diabetes tend to have high level of albumin urea, which indicate kidney damage and increased cardiovascular risk. So patients with eGFR less than 30 mil per minute 30 mil per minute may benefit from this SGLT2 inhibitor as they have higher risk of progression to end-stage kidney. Uh, SGLT2 inhibitor have been shown to reduce the risk of kidney failure and cardiovascular event in CKD patients, regardless of their glycemic status. And the GFR slope reflect the long-term effect of SGLT2 inhibitor on preserving the kidney function and preventing end-stage kidney disease. And that's for my reference and conclude my presentation. And I'm ready for the Q&A session.